Hello, my name is Doug Drossman, and I'm president of the Rome Foundation, and I'm here to tell you about a new product launched at DDW 2017 in Chicago. This program, called the Rome 4 Interactive Clinical Decision Toolkit, is a rather major innovation in terms of learning. What we have done is we have combined the content from the Diagnostic Algorithm book and the Multidimensional Clinical Profile book to address how you make a diagnosis and how you do treatment from a multi-component framework. We're putting that into an intelligent software program, and this program will allow you to use your iPad, iPhone, or PC to go online and obtain information about diagnosis and treatment using intelligent software. The Rome 4 Interactive Clinical Decision Toolkit has been in the works for over 3 years. It began with an idea with the Rome Foundation Board of Directors, where we then partnered with the LogicNets Corporation, which develops intelligent software, to integrate our content knowledge about functional GI disorders and their innovative style of producing intelligent software. And in doing so, we have a program that allows us to do intelligent software that not only provides information for the learner, but records information as we go. As users, hundreds or thousands of users use this program, that information is tracked and that information is played back to the developers, and we can develop pathways to see how they make decisions in diagnosis and treatment. By doing that, this information can allow us to modify the learning tool to adapt to the interests, needs, and values that doctors identify. So in some ways, this is really a living program that will improve as time goes on. In addition to that, the program will be modified through additional versions, both technically as well as in terms of content, as new drugs come into the market. I would also mention that we were fortunate to bring on Dr. Taniya Parvati, who's actually a psychiatrist at the University of California, San Diego. And we have worked with him over the last 3 years as well, and he has served as the liaison to modify the content and play it back to the technical team at LogicNets. He's been an intrinsic part of our program, and he will work with me and the others to develop the program further in the future. Algorithms are created both for diagnosis and for treatment that captures all of this content, but in a way that allows you to go through diagnostic paths. Let me give you some examples. The first would be diagnosis. The user will go online and choose from a variety of common clinical presentations. Let's say abdominal pain with diarrhea. And in choosing that topic, you will be queried on the next step in the diagnostic process. Did you do a history and physical? Were there alarm signs present? Do you do some screening studies? And every step of the way, you can report the progress and even come back at a later time to report the results of your findings. The same is true for treatment. You have a treatment, let's say, of IBS with diarrhea. The information in the program will first ask, are there psychosocial factors to consider? Does the person have anxiety or depression? If not, well then it'll move on to go through the diagnostic algorithm. And it will be providing information about first-line and second-line treatments. It will also incorporate information about the severity of the disease, the psychosocial impact, whether there are any biomarkers or physiologic disturbances. And in doing it this way, you have a multi-component approach to treatment. Now, I think what's really innovative about this is we have introduced an item called the calculator, which allows you to follow your decisions over time. Let's say, for example, someone comes in with chest pain. You might assume that this is functional chest pain after the diagnostic workup is done and put the person on a proton pump inhibitor. Now let's say the patient comes back and the patient is fully resolved, the symptoms are fully resolved. In that case, you're done. But let's say it is not affected at all. You might choose to switch to another agent, let's say an antidepressant. Or the patient might be partially improved and you might add an antidepressant. In other words, decisions are made clinically as to whether your patient has improved, partially improved, or not improved. And based on that, you can go through treatment pathways to add a drug, switch a drug, or stop. And in this way, we are mimicking real time. I think this will have value even in terms of an EMR eventually, because you can bring the patient back in several weeks, monitor their progress, and make decisions that are recorded. So I think you agree that this is something rather unique, innovative, and something that we hope will help you in your learning of functional GI and motility disorders.